Hi, I'm Jack West, medical oncologist at Swedish Cancer Institute, and I wanted to talk about the question of why we might or might not want to do a repeat biopsy on someone who has progression of their disease after a good response on a targeted therapy, the situation that we commonly refer to now as acquired resistance. So the scenario is that sometimes a patient will have a very good response to a drug like Tarceva, also known as erlotinib, or Xalkori, which is known as crizotinib, if they have a specific mutation associated with a probability of a good response. But unfortunately, these responses don't last forever, and whether it is 8 or 12 or more months after the start of treatment and good response, the cancer often will begin to progress. One of the questions that we ask now is there a value in doing a repeat biopsy to see if the molecular characteristics have changed? Now, there are certainly some experts who recommend a repeat biopsy in just about every circumstance to clarify what you're dealing with and whether that might change our treatment plans. However, I would submit that at this point, it is not a standard treatment approach, and there's a few factors here. First, even though we might find a new pattern of molecular markers at that point, in most cases, we don't actually have a specific treatment for whatever we might find on the biopsy. And so, if you don't have a specific treatment that's going to change based on the findings of whatever test you're doing, it doesn't necessarily make a lot of sense to do that test. Now, in some cases, that repeat biopsy may be part of a clinical trial, and that's a different situation. But in terms of standard management and pulling a new drug off the shelf that is commercially available and not part of a clinical trial, there really isn't a clear incentive in almost any case to doing a repeat biopsy right now. The other issue is that these biopsies may not be covered, in fact often will not be covered by an insurer, and even though they tend to be safe to do, there may be some risk of complications with that. And that could be acceptable if there's a clear advantage to the intervention. But if you don't have a clear answer to what can you do with this information and how will this help you, undertaking any additional risk and cost is at least of questionable value. Now, I wouldn't say that doing repeat biopsies and getting more molecular marker information is ever a bad idea. In fact, a huge amount of the advances that we've seen in the last few years in lung cancer and many other cancers has been based on a better understanding of molecular markers and different pathways and treatments focused on them. However, that tends to be in a setting of academic centers and clinical trials. And it's a little different in community practice, where about 85% of cancer patients in the United States get their care. In that setting, if there isn't a clear answer in terms of a clinical trial incentive to doing a repeat biopsy, it may not be the treatment of choice. This may change over time, but at this point, in late 2012 and approaching early 2013, we don't necessarily have a clear incentive to do repeat biopsies in everyone. It is not a standard of care. Thank you. Take care.